On the 12th of January 2010 at 4:53 p.m. local time, Haiti was struck by an earthquake measuring 7.1 on the Richter scale. Its epicenter was 25 kilometers from the capital, Port-au-Prince. In the weeks that followed, the human toll reached a massive 250,000 dead, 300,000 injured, and 1.2 million homeless. 211 survivors were dug out of the rubble by rescue teams from all over the world. The earthquake was the deadliest since the seisma that hit the province of Hebei in China in 1976. A huge number of victims was due mainly to the non-compliance with building codes and overcrowding in Port-au-Prince, a city of around 2,300,000 inhabitants. The earthquake generated a very large number of trauma cases, including amputations, multiple and complex fractures, spinal cord injuries, and cranial traumas. To prevent orthopedic complications from setting in, rapid functional rehabilitation was needed, using an approach based on a number of basic principles. Early post-operative rehabilitation care. A multidisciplinary approach, including medical treatment, paramedical care, and assistance with meeting basic needs, such as water, food, and hygiene. Working as a network, setting up partnerships with other local and international actors, and efficient coordination for more effective action. A decentralized system for detection, referral, and community follow-up through disability focal points, and mobile teams to stay as close as possible to the victims and support them as long as necessary. Handicap International was already running logistic projects in Haiti before the earthquake struck. It now needed a long-term base, so the association moved into a building in the heart of Port-au-Prince, where it set up its functional rehabilitation center. More than 35 professionals are now working in this center: orthoprosthetic technicians, physiotherapists, occupational therapists, logisticians, psychosocial workers, and administrative staff. This is where the orthopedic devices are produced and the patients receive their functional rehabilitation care. In addition to this rehabilitation center, Handicap International has also set up 7 disability focal points throughout Port-au-Prince. These temporary structures help ensure the continuity of care and services in the community for the vulnerable and the injured. They ensure basic needs are covered, such as water, food, hygiene, and shelter, and offer specific assistance, including rehabilitation care and technical aids like crutches, wheelchairs, splints, and other orthopedic devices, as well as psychological support. In addition to these outreach services, Handicap International has also created a mobile multidisciplinary team for the home follow-up of disabled people who've been fitted with devices in the rehabilitation center. During the emergency phase, in the immediate wake of the earthquake, Handicap International posted qualified therapists in more than 14 hospitals to provide hospital-based physiotherapy. As a result of these rapid intervention mechanisms, Handicap International was able to deliver the first temporary emergency prosthesis just 1.5 months after the earthquake. In August 2010, 7 months after the earthquake, and thanks to its operational partnership with Healing Hands for Haiti, Handicap International had fitted more than 300 amputees with temporary and permanent prosthesis. The number of amputees is estimated at 4,000, most of them lower limb amputees. Statistically, there are 60% of women and 40% of men, as well as 30% of children in each group. There are also many people with motor impairments due to lesions to the central or peripheral nervous system. Most of the traumatic pathologies encountered were different types of wounds and fractures caused by crushing, cuts, or shocks. Teams later came across infections in open fractures or inside plaster casts. In trauma situations, the decision to amputate may have to be a first resort to save the person's life. The choice of orthopedic device and so the functional prognosis depend to a great extent on the level of amputation. For the thigh, the level offering the best prognosis is at the junction of the lower and middle thirds. For amputations of the leg, the ideal level is the middle third. Post-operative care requires the intervention of a multidisciplinary team from the outset in order to prepare the individual and the stump for the temporary prosthetic device. Early psychological support is an essential component as it helps the person accept the loss of their limb, come to terms with their new body image, and gradually piece their life back together.
J'ai envie de remarcher, même si c'est pas la même vie qui va recommencer, mais quand même, je sais que la vie continue. La vie continue avec un pied en plastique.
The rehabilitation process is a long one and begins with care for the stump, treating the scar tissue and reducing the edema with specially designed bandages. Early functional rehabilitation is essential for preventing muscle contractures and conserving range of movement. Patients also need to understand the importance of adopting the right position while they're confined to bed. This is crucial for preventing complications. The first time they stand up is always difficult and painful for patients who've been lying down since their operation.
Donc le premier lever est dur pour différentes raisons, c'est-à-dire qu'ils sont déjà allongés depuis pas mal de jours, ce qui veut dire qu'ils ont musculairement, ils ont perdu du muscle et ils n'ont plus l'habitude de la position verticale. Donc en général, quand on les remet debout, le sang qui a l'habitude d'un corps allongé se retrouve subitement verticalisé. Donc souvent ça tourne, plus ils sont allongés, plus ça tourne. Et deuxièmement, tout le sang qui normalement se retrouve dans la tête descend et il descend dans le moignon entre autres. Donc ce moignon qui n'est pas cicatrisé prend beaucoup de sang en une fois et ça fait très mal. Plus on attend, plus on laisse les gens allongés, plus ils ont de chances d'avoir des infections respiratoires, d'avoir des escarres, d'avoir des rétractions musculaires, articulaires, d'avoir des fontes musculaires. Donc c'est un peu une course contre la montre et contre la douleur, parce que quand les gens ont mal, ils n'aiment pas se mettre debout, mais il faut.
Patients are helped to recover their motor functions by learning to manage the different transfers they'll need to be self-reliant in their day-to-day lives. Verticalization, passive and active movement of the limbs and muscle strengthening exercise help prevent wasting and maintain the person's range of motion. At the same time, teams continue to address pain management and bringing the feeling back into the stump. The temporary emergency prosthesis was first developed 15 years ago by a French company called Proteor in response to a specific request by Handicap International. This type of prosthesis consists of an adjustable femoral socket and temporary devices for transtibial and transfemoral prosthesis used in assembling and aligning the sockets. Since it was first designed, Handicap International has used it in a number of countries in the wake of natural disasters or armed conflict, including in Iraq, Kurdistan in 1992, in Bosnia in 1993, in Turkey in 1999, in Iraq in 2003, in Iran in 2004, in Pakistan in 2006, and finally in Haiti in 2010. This technology is designed for mass temporary emergency fitting of transtibial and transfemoral amputees, without a power source and in the most extreme conditions. It mustn't take more than a few hours to make before the patient's gait training begins.
Donc la prothèse tibiale, telle qu'on la fabrique ici, présente une emboîture en Dynacast qui a été directement moulée sur le patient, qu'on a ensuite relié à des montants latéraux et postérieurs qui eux-mêmes se rejoignent une cupule qui va permettre le montage des différents éléments jusqu'au pied. La prothèse fémorale est composée d'une emboîture préfabriquée en polypropylène que l'on aura choisie en fonction des mesures que l'on aura prises sur le patient. Donc on a 5 tailles différentes d'emboîtures qui seront ensuite adaptées sur le patient. Cette emboîture est reliée à 2 montants latéraux qui eux-mêmes se rattachent à une cupule. Cette cupule nous permet de faire le montage des différents éléments sous-jacents pour relier le pied.
The first step is to take all the measurements needed, which are noted on the patient's measurements card. The stump is protected with plastic film and a cotton cap, and then wrapped in a latex insulator. The head of the fibula, the tibial crest, and the painful areas are padded with patches and strips of foam. The technician applies a series of wet Dynacast bandages, makes sure they are tight enough, and then smooths them over. He marks the patellar tendon bearing and counter pressure zones. Once the polymerization is complete, the socket is removed from the stump. A vertical incision is made on the outer face of the socket's brim to make it easier to remove. Once the socket has been withdrawn, the proximal limits of the brim are traced and then cut along this line. The edges are then sanded down to make them smooth. The technician then tries the socket on the patient to determine the frontal and sagittal alignment. For this operation, the patient must be standing. The socket is then sent to the workshop where the temporary emergency prosthesis is assembled with all the necessary modular components. The tube is cut to the required length using the measurements noted on the patient's card. The temporary device is then fixed to the prosthetic leg, which is made up of the tube and the prosthetic foot. The temporary device can have 3 or 4 upright bars. These upright bars are adjusted to obtain the static alignment of the prosthesis with about 5 degrees of flexion. The socket is temporarily fixed to the device using mounting screws or copper rivets and adhesive tape. The static alignment is given a final check before the gait training session begins. A supracondylar belt is added to hold the prosthesis in place. Depending on how tight it needs to be, the patient will be given 1 or 2 cotton caps. For the transfemoral prosthesis, the choice of adjustable socket depends on the circumference and length of the stump. The 5 available sizes cover about 80% of needs. They're assembled according to the alignment principles for the transfemoral prosthesis.
Donc on part derrière, hop, et tu viens commencer de cette façon-là. Et quand tu fais ton bandage, tu le fais toujours de travers comme ça. Ne jamais commencer ton bandage en circulaire. Jamais faire de bandage en circulaire. Avant, tu l'avais fait un peu en circulaire, toi, quand tu es venu. Hein, d'accord? Donc jamais comme ceci. Toujours de biais.
At this stage in the rehabilitation process, it's essential to keep the stump bandaged to control residual edema and shape the stump. The patients must learn to apply the bandages themselves.
Et puis ensuite, dégressif, de moins en moins fort, moins en moins de pression, et tu montes toujours de biais. Jamais tu monteras comme tu as fait avant, c'est-à-dire en cylindrique. Toujours de biais.
Rehabilitation is essential to help the patient regain a maximum amount of functional autonomy with the prosthesis. With this in mind, the therapist will suggest a rehabilitation program adapted to the patient's clinical situation and professional and personal activities, consisting of exercises and progressive intensity. At the first fitting, the technician makes a series of final adjustments to the prosthesis. Then the work on progressive weight bearing and static balance can begin. Gait training begins with learning stance control and how to balance weight correctly between the sound leg and the prosthesis. This phase can be painful at first, but becomes less so with the exercises and daily practice. For example, the patient may be asked to stand with each foot on a set of scales to check they're putting weight on their prosthetic limb. Next is gait training, beginning with the parallel bars to work on the gait cycle and the different stages in this cycle, which are prosthetic heel strike, mid-stance, heel off, toe off, swing phase. At this point, after analysing gait deviations and talking to the prosthetic technician, any other necessary adjustments can be made to the prosthesis.
Aujourd'hui, elle est venue, elle était beaucoup plus ouverte, plus décontractée. Et puis tu vois, là, elle marche avec le sourire en plus. Elle dit qu'elle a un petit peu mal, mais on voit qu'elle est quand même contente d'être là, de mettre la prothèse et de voir que ça évolue bien après 2-3 allers-retours. Elle y va vraiment de manière très franche. Et puis on sent qu'elle est motivée, quoi. C'est pas celle qui se plaint, qui dit j'ai mal, je veux arrêter.
Sometimes there are complications with the stump, as here with Island. She's gradually developed a subcutaneous ulcer which has become increasingly painful. The problem was detected by the team during her gait training, which must now be suspended. Islam needs to be referred to the MSF hospital for treatment of the ulcer before her rehabilitation can continue.
Donc c'est ça qui fait mal, d'accord? Donc on va t'envoyer à l'hôpital, d'accord? Pour prendre en charge ça, qu'ils évaluent exactement ce qu'on peut y faire, certainement peut-être l'ouvrir et faire le soin, d'accord? Donc ils vont s'occuper de ça, et comme ça une fois qu'on se sera bien occupé de ça, on pourra reprendre correctement la prothèse et ça fera plus mal normalement, d'accord? Et on t'envoie à l'hôpital histoire de dire que on prenne bien en charge ça, qu'on soigne ça tout de suite, et comme ça après on peut continuer.
Island is taken to the MSF nurse who lances the ulcer. The final stage in the rehabilitation process involves functional training in situations that reproduce the kind of obstacles encountered in people's day-to-day living environment. The physiotherapist can stimulate an obstacle using a simple concrete block or propose an exercise involving the manipulation of tennis balls that puts the patient in a more complex situation. With the help of some old tires, he can also simulate unstable terrain to help the patient learn to manage and control their prosthesis in real-life situations. The decision to discharge the patient from the service is taken by the team. Follow-up visits are scheduled 15 days and 45 days after delivery of the temporary emergency prosthesis. This follow-up is important for making any necessary adjustments to the prosthesis and noting volume changes in the stump in preparation for a new socket or for adding another cotton cap to make up for any loss in volume. After an amputation, it usually takes a few months for the stump to be fully stabilized. The patient leaves with a leaflet detailing daily hygiene and maintenance measures. Once the stump is stabilized, the patient is provided with a permanent prosthesis that has two major differences. The socket is made of polypropylene on a plaster mold and is much more functional than the temporary socket. The other important change is that the prosthesis is made to resemble the sound leg. The patient now no longer needs to make regular visits to the center. He or she will only come back if there's a problem with the device. Functional rehabilitation is not an end in itself. It's a means for helping people regain their place in society as quickly as possible. This has been the case for Island, who's now gone back to school to continue her studies, and also for Miriam, another patient who, thanks to her transfemoral prosthesis and the functional rehabilitation she received in our centre, has been able to return to her job as a librarian at the University of Ontology in Port-au-Prince. It's also the case for many other people who've received treatment, care and support in the rehabilitation centre or in the community via the disability focal points.